All right. Well, tonight we're talking about the cardiovascular system. It's really a unique case because you don't see it the rest of the semester, but this next exam, even though you just finished taking an exam last week in the course material, this next exam is only on 2 chapters. It's only on blood and the cardiovascular system. Now, the cardiovascular system is truthfully a long chapter, but a lot of it is anatomy. And so in that sense, you do have to know some anatomy, and I'll go over which ones are more important in course. You need to know a lot of the anatomy for lab. And so you really have an advantage this week for those of you listening later. If you can catch up or even work a little bit ahead, you'll actually be in a really good position for the exam. Next week, it's not a lot of work, and in fact, the reading guide simply tells you know everything there is to know about the cardiac cycle. And that's pretty much all it really says. It tells you to focus on a couple of figures, but it doesn't really leave much more than that. And while seemingly that's a simple and logical thing to really understand, but sometimes it's hard to try to get it all together, and so it does take some students a little bit longer. In fact, the next week, the whole section's, just a few pages really comparatively. So if you can get started now, I think that would be really advantageous for you for next week. And well, next week we'll spend the whole time talking about the cardiac cycle and how to kind of put it all together and how to read and understand those very overwhelming and intimidating graphs that are in figures that are in your text. Also, for those of you that are listening later, and for the 2 of you that are here tonight, the 10th edition diagram of the cardiac cycle is a little bit clearer and easier to understand than the 9th edition. So I will be attaching that next week in the note early in the week, so probably late at the end of this week, in the notes from instructor section. I'm going to put another weird looking diagram that's kind of funky looking, but it's really simplified the cardiac cycle. And then I'll give you the 10th edition for those of you still using the 9th edition text. I'll give you the 10th edition diagram for you to also go by on the one that's in the text. Okay, so that's kind of looking forward to next week. This week, really, there's a lot of pages, but a lot of them are just looking through the diagrams and kind of understanding what's going on. In particular, I'm actually starting, this is, partway through the chapter already, because the first several pages are just anatomy, really. In fact, for those of you in lab, it's really important that you do learn not only all the parts of the heart inside and out, so you need to have the blood supply to the heart learned very well through APR. You'll see a lot of APR diagrams on the next exam as far as the blood supply to the heart. And people get some of those really mixed up, so know your orientation of the heart really well too. But this particular diagram, which is figure 20.7 on page 673, if you're in lab, you have to know all of this very well. You need to know, and that includes the sinuses, the valves, the muscles. I can tell you right now as a hint, and get my little green arrow to work here, that people mix up the chordinae, tendineae, and the papillary muscles really easily because they're kind of close together here, as well as the valves. So when you look at the diagram, and there's a lot of heart model pictures on the exam for lab 2, when you look at those, make sure you know exactly where it's pointing. If it's pointing up here versus right here versus right here, I can tell you that this term is an important term to know, and to know exactly where it is so that you can get it correct. All of these terms are important terms, but this one is the one I see most students miss right here. And then there's a little bit more specific, and when you're looking at those heart muscles, they'll show you some other things. The reason I brought this up, though, is in the course, it's just as important that you understand the 4 chambers of the heart, the 4 valves that are involved, the semilunar valves, and the tricuspid, bicuspid, or sometimes we call them the mitral valve over here. These are called AV valves, the atrioventricular valves. They have like 3 or 4 names, though, so you need to make sure you know all of them. So this is the left AV valve or the bicuspid valve or the mitral valve. And any of those three may be given to you as either a multiple choice question or fill in the blank, and you'll need to be able to at least know that they're all the same and that they're over here on the left side, and of course then the right AV valve. And then the pulmonary semilunar valve goes to the pulmonary system, and the aortic semilunar valve is just before the aortic arch. So, and the aorta itself is part of the beginning part of the aorta. You need to know those 4 valves really well, 4 chambers really well. You need to know both the arteries, so things that leave the heart. So this one here in blue is the pulmonary arteries, the pulmonary trunk that goes into the left and right arteries, and the aorta, which leaves the heart. Artery is anything that leaves the heart. It doesn't matter whether it has oxygenated blood in it or not. A vein subsequently then carries blood to the heart, whether it's non-oxygenated, such as in the fact of the superior and inferior vena cava, or oxygenated, such as the left pulmonary and right pulmonary veins. So you need to know all of this structure for both course and for lab, but students that don't have the lab sometimes skip over this part and really miss questions on the next exam on the anatomy, and then it messes up the whole idea of being able to take a blood cell, an arbitrary blood cell through the heart in the correct order. And that's often a question in the next exam. There's several different questions that ask you to do that, starting with the inferior vena cava, starting with the pulmonary artery, and then taking it through the heart. So there's lots of potential scenarios. So you need to know that well too, is how the blood travels through the heart, what the purpose is of those valves, and when the valves are open and when they're closed, and we'll discuss that more next week. So this is a really good start off for both lab and lecture on making sure you understand the components of the heart. Now, like I said, for lab, you need to know everything that's on this page. For course, I would at least know the main veins coming in, and that includes the pulmonary circulation as well, the 4 main valves, and the 4 chambers of the heart. So you have the left and right atrium and the right and left ventricle. You can distinguish between the two, and you're going to need to make sure you have your orientation correct, because sometimes they'll flip it. The left ventricle is a little bit bigger, and it has a thicker muscle, as you can see here. The muscle here is thicker because it has to actually contract and push the blood from the ventricle through the aorta, through the whole body, where this particular side goes only to the lungs, which are really close by, just right here and right here. And so they don't need as much force in order to carry the blood to the circulatory or to the respiratory system and then back in to the heart. That's an important difference between the right and left. So when you're looking at it anatomically, just kind of pay attention which one looks larger, which one has, if it's a cross section, which one has a thicker muscle wall. Now, another thing that you'll have to do in both lecture and lab is you'll need to be able to distinguish the differences between cardiac muscle, skeletal muscle, and smooth muscle. If you don't remember, some of those differences are in the histology chapter. I have to go back. I want to say chapter 5, but it's been so long since I taught 264, I could be wrong. Oh, see, that's integumentary. All right, so tissues in 131, sorry, chapter 4, pages 126 to 127 has some histology differences, but then you can see structural differences as well if you read through there. So if you need a refresher, go to pages, figure table 4.14 on 126 and 127 to kind of get the idea. You will have questions about the differences with cardiac muscle versus skeletal and smooth muscle, not just anatomically, but how they function, and we're going to go over this tonight, how they function with action potentials. And so you'll need to know that as well. So when it comes to lecture, so let's focus on lecture a little bit, because in lab you got to learn it all. In lecture, if you understand the main components of the heart, if you understand and know the names of the of the main veins going in to the heart and out of the heart. That's a good start. And then, of course, once again, knowing the valves. It's really simple now. Well, back in the day when it was just bicuspid or tricuspid, you had to figure out a way to learn how that is. But now that you can just use right AV and left AV, it's easy between the atria and ventricle. As far as any other things, the only other thing in lecture that may be of benefit to you is this picture. I'm going to stop this one and show you another one, at least initially, as far as any type of anatomy or histology is concerned. Let me get this up. Find it right here. This is figure 20.4 on page 669 in the 10th edition. There are a few questions, not a whole lot. There are a few questions, though, about the layers of the heart and the difference between the myocardium, myo meaning muscle, if you recall, so muscle of the heart, and then the epicardium, some loose connective tissue there, and some simple squamous, as you know, lines all the body organs as well as body cavities. And then finally, a little bit internally here, the trabeculae carneae is another anatomical term that students miss a lot in the lab exam. So just a little hint there. Make sure you know what this looks like, not just in this diagram, but in an APR diagram or in a heart model diagram. Those are going to be your kind of three choices in the upcoming lab exam in a couple weeks. So kind of know the layers of the heart, and we'll talk some more about the myocardium and how it's actually stimulated to contract and why that's important to know why that contracts together. All right. The other thing that is shown at the beginning of this chapter is this. And this we actually spend more time with, I think, in a couple weeks when we talk about the circulatory system. But I think it's a good overview of showing you what this cardiovascular and circulatory system is all about. So this shows in general, and this is in your chapter also. It's at the very beginning, I believe. Let's see if I can get there. This is figure 20.1 on page 666. Like I said, we'll spend more time talking about this. So after the endocardium is made up a little bit of that with some other parts. It is is made up of the trabeculae carneae, but there's also a little bit else with it. I don't think you need to know that for, let's see, I don't think you need to know that for lab or lecture, as long as you know what it looks like in the heart. And you'll see that there's a crista terminalis that is a ridge right at the same time, right where the myocardium and endocardium reach. But I don't believe that's in your, I'm almost positive that's not in your lab terminology. I think it's just the if I can say it right, trabeculae carneae. So you do need to know that though. Okay, and you can't call it endocardium. You gotta call it trabeculae carneae because it's a specific portion of that. Okay, so looking ahead, what we do is we spend this week in cardiovascular, next week in cardiac cycle, still cardiovascular, and then Chapter 21 after your next exam, which I can't believe is coming up already. It feels like you just had an exam, which you did, maybe because it took me so long to review them all. But then Chapter 21 is on vessels and circulation, and so we spend 2 weeks on circulation and vessels and thermodynamics and things like that. Not to scare you, thermodynamics is kind of scary because it's physics, and a lot of people like physics. But after that, then we go into respiratory and then the other systems. And so this is more along the lines of what we see in the future, but it is in your cardiovascular chapter. And it's just giving you a good overview, though, of what's happening, where the blood's going. So you can see that as it comes back from the body here, comes into the right side of the heart, gets pumped to the lungs, gets oxygenated, comes back to the left side of the heart, and then is pumped out throughout the body, and then again gas exchange occurs in the capillaries, and that's exam 3, gas exchange and all that. So like I said, this is a little bit ahead, even though it's in this chapter, chapter 20, it's the first diagram. But what I think it's trying to show you is that there's two different circulations. There's the pulmonary circulation, which goes to the lungs and back, and the systemic circulation, which goes from the heart to the body and then back to the heart. You do need to know the difference between systemic and pulmonary circulation, and which is oxygenated and which is not. Your text has decided to use blue for deoxygenated blood and red for oxygenated blood. And I say your text because there are other texts and other resources out there that will use blue for veins, whether they're oxygenated or not, and red for arteries, whether they're oxygenated or not. And in the pulmonary system, it's backwards. So the blood that leaves the heart is deoxygenated. The blood that enters the heart is oxygenated. So just really be careful. Don't just assume that blue is always a vein and red is always an artery, because like I said, your book actually does it with oxygenation versus deoxygenation. And I want to say the text we had before this one did it the other way. So like I said, if you're using other texts or you're going online to look up other resources, which I encourage you to do, if you need the extra visual helps, aids, then just be careful. Just know which is oxygenated, which is deoxygenated. That's actually a test question. I think it might even be on the final, comprehensive final, that all veins are deoxygenated, and of course that answer would be false. So just keep that in mind. I'm going to sneeze, so excuse me. Excuse me. Sorry about that. Okay, so let's stop looking at this because, like I said, to me that's more in the future. All right. So once again, cardiac muscle contraction is fairly straightforward. It's something you learned in 264 a little bit. Just do a refresher. Thank you very much, Melissa. Refresher on that. That's not some. This, however, the electrical conduction of the heart is a whole different matter. And so I want to spend a little bit of time with this and talk about action potentials in the heart. So this is it's not a fundamental figure, but it should be. This is the conducting system of the heart. And you didn't know this for both lecture and lab. This is figure 20.13 on page 678. And what it's trying to explain is that there are specialized tissue in the heart. There's a little node of it here, so a little grouping of the tissue here. There's a little grouping of a tissue here. And then it comes down and it kind of splits into these fibers. They kind of look like axons and dendrites. They're not, though. It's specialized conductive tissue, so it has a tendency to transfer action potentials, kind of like nerves do, but not quite. Nerves. So what we see here is this is called the sinoatrial node. Notice it's in the atria, up high. The AV node, or atrioventricular node, is really close to the ventricle. This down here has a couple different names. It's been called the bundle of His, H-I-S. It's called the AV bundle. It's called, sometimes people refer to it because it's in the septum. They may call it septum conductive tissue. Your book calls it the AV bundle, which is fine. The common term, or the term we used to use, was bundle of His. And you may see that in your exam, and you may see that in your text as well, but it's all the same thing. And then they branch out to these Purkinje fibers, which kind of spread throughout the cardiac muscle. And of course, this is just a cross section, so you have to think of it as a 3D thing where all the muscle on this other side that we've cut out also has a Purkinje fiber or other fibers branching from it. Well, the really unique and wonderful thing about this is it allows, because of the conduction of the heart of stimulating action potentials in order to cause contraction, the atria will always contract together. So atria is plural, atrium is singular. So the atria, both left and right, will contract together. And then the ventricles will contract together, the left and right ventricles. And that's really essential in order to get the blood propelled or pushed forward. As you know, the heart is a pump. And really that's its mechanical job. It's just to pump the blood in and out, or receive the blood in and pump the blood back out to the respective areas. So it's the blood that does all the work, even though heart gets all the credit for it. So please pay attention to this. What essentially happens is we stimulate the SA node. The SA node travels to the AV node. At the same time, the atria are pretty small. It travels throughout the cells. And you may remember that the cardiac muscle has intercalated discs, which allow conduction to happen very, very rapidly. So by the time it hits the AV node, it's also spread throughout the atria, and the atria are excited. Calcium's released, atria contract. There's a slight delay from the AV node receiving the signal to the AV node pushing through the signal, and that's transferring the signal through these AV bundle and the Purkinje fibers, and that slight delay is there so the atria have time to contract and propel the rest of the blood towards the ventricles and then relax. And then the Purkinje fibers are great because the ventricle is a much bigger muscle. It's going to need a little help. So you're looking at this, these fibers spreading throughout the muscle. And of course, I'm doing this with my hands, but you can't see it. But it spreads throughout the muscle so the ventricles can contract together. And that's also important because you want to be able to have, if your heart isn't contracting at the same time, you end up in a fibrillation mode where you're not pushing blood out properly. And if you're not doing that, if you're not pushing the blood out to the lungs, it's not going to get oxygenated. If you're not pushing it to the tissues don't get what they need. And so it ends up that you're not getting any blood anywhere. And as you know, waste products can start to build up, and we can have some severe damage if it's not contracting properly. So this aspect of having this conduction system so that the atria contract together and the ventricles contract together is really important. It's really essential for this pump to actually work properly. So spend some time with that figure. Like I said, it's not a fundamental figure, but it probably should be. And so let's look at the conduction properties. Now, it is not like a typical action potential. I'm going to show you. I think this is a typical action potential. Oh no, that's ECG. We'll talk about that in a minute. All right, which is also preface to lab next week. But let's see, where is that? Oh, maybe here. Okay, so I like this diagram because it shows both and kind of shows you the differences. This is a fundamental figure. Is figure 20.14 on page 680. And like I said, I like it because this is your typical action potential. So a little refresher from when you talked about nervous system and skeletal muscle system, kind of the same thing. In skeletal muscle, you have a threshold. And once that threshold is released, it's an all or none action potential. Either happens or it doesn't. So when the threshold is released, you get a depolarization, a repolarization, a little bit of hyperpolarization, and then back to normal, and then you can go again. If you recall, skeletal muscle increases its strength of contraction either by increasing the frequency, so you stimulate it more frequently, or you recruit more, so temporal and spatial summation, you recruit more fibers, muscle fibers, to get a stronger strength of contraction. That's one of the big differences between skeletal and cardiac muscle. Now, cardiac muscle has the same type of thing. You hit a threshold, you start getting a depolarization. Notice that there's a third thing here, though, right here. So sodium gates open, potassium gates or potassium channels are closed, but you see these voltage gated calcium channels begin to open. Now the calcium channels are really slow comparatively. So sodium's going to go, it's going to start flooding the system. You're getting this depolarization. In fact, you can start repolarization. And then the gates right here at 2. So same thing happens, sodium closes, but by here, finally those calcium gates are open. And because the calcium's open, and the potassium's open, you're getting this plateau. And this plateau phase can actually, that's why it has this little bar here. It can be, this can change. The phase can change depending on the amount of calcium and the stimulation for the calcium channels to be open. One of the things that stimulates calcium channels to remain open is epinephrine and norepinephrine from week 2 when we talked about the autonomic nervous system. So remember the autonomic nervous system, sympathetic stimulation increases the strength and the frequency of heart muscle contraction. This is how it does it, by keeping those calcium gates open, and the longer the plateau in an action potential, the stronger the force of contraction will be when it contracts. So it's a really nice correlation. Well, then finally, you see repolarization occur because the calcium gates close, and then the potassium gates are still open, so they'll cause repolarization of the cell and then back. And the amazing, wonderful thing about the cardiac muscle is it does this all on its own. It doesn't need any stimulation from the sympathetic or from the parasympathetic to cause that to happen. It's actually self-conduction. It's a self-conducting tissue, so it can do it on its own. It has kind of what we'd say leaky channels, and it will cause this to occur. It's a little bit slower than an average heart rate, so we do see mostly sympathetic stimulation, and most of us have a little bit of that going on so that we have a little bit faster heart rate than it would be on its own. But isolated, a heart will still contract on its own. And depending on which animal or organism it is will depend on how long the heart will do that. So hearts will do that, for instance, in frogs for a long time, and humans for a few minutes anyway. It will do so until it runs out of energy source. Then it will stop. But it still needs, like I said, this calcium gate to open, and once again it's really slow, so it takes its time, and that's why you start seeing repolarization beforehand, because the potassium gates have opened and the sodium have shut, just like they do here. But then when the calcium's finally open, it counteracts the effects of the potassium. So spend some time learning about that. It's actually pretty straightforward. A lot of students miss it though, because I don't know why, because it is different, I guess, than this typical action potential. But if you understand the role of calcium, how it counteracts potassium, it's pretty straightforward. I would spend some time reading about the autorhythmic motion of calcium. In fact, I'm going to show you that. That's the next figure. It's 2015. And this just shows you what happens at the pacemaker cell. And once again, those pacemaker cells can be influenced by, this is it, I believe, they can be influenced by epinephrine and norepinephrine. So it's just showing on its own, without any stimulation, it's still going to go through this pacemaker. Potential is just a little slower, and it doesn't have as nice of a plateau. Okay, so epinephrine, norepinephrine keep that plateau, gives a stronger strength of contraction. So we get more blood that's actually propelled out. Now, on a normal contraction at rest, you're looking at about 70 to 75% of the blood in the ventricles gets pushed out. So there's some remaining. When you have a stronger force of contraction, so you contract harder, then you actually can push out 85 to 90% of what blood is in there. And we talk about that in a couple of weeks when we talk about ejection fraction. So just know that there's a potential to get more blood out. You do need to know the cardiac output equation, which I think we discuss next week, that is heart rate times stroke volume. You need to know this really well. Equals stroke volume times heart rate. And so the stroke volume is how much blood comes out per stroke, per beat, so to speak, and the heart rate is beats per minute. So ultimately your cardiac output is in milliliters per minute. It usually hovers between 5 and 6 liters, and so we do, instead of saying 5 to 6,000 milliliters, we do translate that to 5 to 6 liters per minute. So do know cardiac output equation. We're going to study a lot more in the next couple weeks. But this is one way we can affect cardiac output, is we can have a larger stroke volume if we contract it harder. All right. Well, once again, as you know, electrical action potential is all electrical type activity, just like it is in the nervous system. And so how does that translate to actual contraction? Well, we've found a way to measure the electrical activity, and this is, like I said, kind of a preview into next week. Because we talk about, in lab anyway, you have to do an ECG lab where you learn a little bit about what this is and how to measure it and what kind of degree or angle, what the leads are like. You also have to know this for lecture. This is on page 682, figure 2016. Electrocardiogram is either EKG, that's the old German spelling, or ECG, which is the current American or English spelling. Let me just emphasize this for anyone who's listening. This is the electrical conduction of the heart. Depolarization subsequently will lead to contraction, but so many students miss on the exam when they see that atrial depolarization, for example, the P wave, corresponds to the depolarization of the atria. In other words, the electrical changes that occur in the atria prior to contraction. Well, as you know, those questions can be a little tricksy on the exam, and so the exam may say, the P wave corresponds to A, atrial contraction, B, ventricle contraction, C, atrial relaxation, D, ventricle relaxation, or E, none of the above. Well, the answer is E because it isn't corresponding to contraction, it's corresponding to depolarization. It's corresponding to the activity prior to the contraction, or the activity after contraction prior to relaxation. And so please make note of that when you're doing your quiz and when you're doing your lab and when you're doing your exam, to pay particular attention as whether what it corresponds to is the electrical activity only. It doesn't correspond to contraction. Ultimately, contractions will follow, but this is not a contraction diagram. It's an electrical activity diagram, the change of those membranes. So P is related to atrial depolarization. It's small amount of muscle that's being depolarized. The QRS, this huge complex here, is ventricle depolarization, so prior to contraction. And then the T wave is ventricle repolarization. So the first question a lot of students ask is, well, where is atrial repolarization? Well, it's right here, and it would be kind of like this, right about like that. But because this electrical activity is so large, because there's so much more muscle, cardiac muscle that's being stimulated, that's being depolarized, it just gets lost in the electrical activity when you look at it. And so you don't really see it, but you know it's in there. So atrial depolarization occurs, atrial repolarization occurs, ventricle depolarization occurs, and ventricle repolarization occurs. Now, we've learned that electrical activity can tell us a lot about how well the heart is functioning, and when it's not functioning really well, what potentially is going on. Figure 20.17 on page 683 shows some things that when things go awry. And if you're in lab, you will see several of these, and you'll need to kind of pay attention to what some of these are, because they're on the next lab exam that's about. I know I'm jumping ahead 2 exams. It's on lab exam 3. But you will need to know, it's taking a long time apparently to get in here. But it takes an ECG technician anywhere from 9 months to a year and a half to really understand how to read it. And of course then a physician also looks over it and reads it. But there's some very telling changes that can occur in the electrical activity. So here's an example of fibrillation. So if the heart is not contracting together, the ventricles aren't contracting together, you get lots of little contractions with no definitive, or lots of little electrical activity with no definitive depolarization, repolarization. So what's happening is it's contracting in little places all around, but it's not contracting together as a whole. Back when I was at BYU, they allowed us to do this experimentation on an animal and have it in fibrillation, and and actually hold the heart while it was in fibrillation, and it feels like you're putting your hand in a bucket of worms. So you can feel contractions happening all around with little bits of depolarization, but no real uniform or together type of depolarization subsequent contraction. In atrial fibrillation, you see that the QRS is really fast. So atria's not depolarizing together, so you don't see P waves really. Because of that, the ventricles are stimulated, are really short stimulation and really short contractions there too, because they're not. It's also going to have a problem with that. So both fibrillations actually can result in death over an extended period of time. So, just different things. You don't have, if the ventricles contract before the atria, then you don't really see depolarization happening here, so you don't see P waves. Here's another one where they're not coordinated because you have a heart block, so there's not a good communication in that electrical conduction that we looked at with the SA node and the AV node. Or if the bundle branch, so the AV bundle branch is blocked for whatever reason, it's not going through the septum and out through the Purkinje fibers, you're going to see a contraction that's a little bit longer because it's not as coordinated. So just know that you have to know, you don't have to know like every one of these, but know that you can tell that there are differences in the course. In fact, table 20.1 on page 684 gives you some symptoms and conditions, and I would at least kind of review those. For lab, we ask you to look at them a little more carefully. We show you EKGs in a video, I believe, of more of those, what happens with tachycardia and bradycardia and what that means. You need to know what some of those terms mean for lab. So if you're in lab, pay attention to 20.1. If you're not, then just kind of review the table 684 and get a feel for what an arrhythmia will do, or what symptoms there are and what may happen with those. And then the remainder of the chapter is cardiac cycle, which we will spend a ton of time on next week, talking about before your next exam. So are there any questions at this point in time about the heart, the conduction of the heart, the action potential of the heart, or potentially, let's see if there's anything else. Like I said, all the other stuff I think is pretty straightforward. That's table 2. Yeah, so that's next week too. So the rest of it, the cardiac cycle then takes the ECG, the pressure we see, the volume we see, and the sounds, the heart sounds are the closing of the valves. As the blood is pushed from the atria to the ventricles, the valves close to prevent backflow, and then as it's pushed out of the ventricles, the valves are closed to prevent backflow, and that's your heart sound, lub-dub, lub-dub. And so we take that, a typical time period of a heartbeat, from one heartbeat to the next is a cardiac cycle. So we take that, the electrical conduction with the ECG, the pressure, the volume, and those sounds, we put them all together, and that's what a cardiac cycle is. So if you're feeling fairly comfortable with this information, you think you have it, go to table 20.2 on page 686, 688, 20.18, and 20.19 on 689. Spend the rest of your time focusing and trying to learn the events that occur during the cardiac cycle, and we're going to bring all that together next week and try to make it a little bit easier to understand. Okay, I'll leave it open for questions at this time.